Hello, welcome.
Can you hear me?
Yep, I can hear you.
I can't hear you. Wednesday. Oh, wait. Awesome. Can you hear me? Okay.
I
Good.
can. Yeah, we're live right now, just so you know.
Awesome. Okay, great.
Yeah, great. So I'm just going to introduce you to our audience.
Mhm.
So we have Dr. Blaise Aguirre here, MD, and he's a child and adolescent psychiatrist. He is a practitioner of and trainer in dialectical behavioral therapy, DBT, for borderline personality disorder and associated conditions. He is the founding medical director of 3 East Continuum of Care, an array of programs for teens which use DBT to target self-endangering behaviors as well as the symptoms of borderline personality disorder, BPD traits. Dr. Aguirre has been a staff psychiatrist at McLean Hospital since 2000 and is nationally and internationally recognized for his extensive work in the treatment of mood and personality disorders in adolescents. He lectures regularly throughout the world, this year all by Zoom. He is an assistant professor in psychiatry at HMS. He is the author and co-author of multiple books, including Borderline Personality Disorder in Adolescents, Mindfulness for Borderline Personality Disorder, Coping with BPD, and DBT for Dummies. So welcome. Thank you for being here for BPD Awareness Day.
Awesome.
Yeah, welcome.
Great. Now, I haven't used this platform before, so I'm going to be asking for help.
Yeah, no worries. It's a little bit new to us too. So,
Yeah. So I
so
can
you,
share my slide. I see that there's a share link.
yeah. So share, and then the suggestion would be to go to slides and then from your computer. That's what we tried this morning, and it seemed to work.
Okay. We support. Okay. Upload file. Let's see here. Desktop. All right, 1 second. I think I need to file, save as, desktop.
We noticed that this morning that the slides open, but that we weren't able to see it as they were moving on the screen. So I had somebody send them to me, and then I was able to do it. So that might be an option if it doesn't work on your end.
I'm going to send these to you right now, and
Okay,
as well. Let's see here. Let me just make sure it's the right one. Yeah. Okay. And all right. Send. All right, I've sent those to you.
Okay.
Let me just try one more share slide.
It seems like the share screen doesn't work. Because it doesn't allow you to like move to the next screen. So it seems like
you'll do it.
Yeah, I can do it. Yeah.
Okay. Awesome.
All right. All right, just one moment, folks. I'm just saving it here. Okay, it's just uploading now.
Sounds good. How's the day been? How's everybody doing?
Yeah, I'm good. Yeah, we had Sherry Van Dyke here, and she spoke this morning. Yeah, and then we had a person with lived experience share the story, and a family member. And so, yeah, I think it's been going well, minus a few glitches with technology. Yeah. How's your day going?
Good. I actually gave a massive grand rounds, which I'd totally forgotten that I was doing on.
I saw that, yeah, and that was on self-hatred.
Yeah, and I can send you those slides. It was very well received. I'm happy to send you these slides as well, and and you can share with folk if they want.
Sure, yeah, I think that's a great topic. Okay, so there we go. Does that look correct?
1 second. Yes. Yeah.
All right. You just let me know when you'd like me to go to the next slide.
Yeah. All right. So everybody, thank you. It's 3:30 on the West Coast, right? That's your time.
I'm in Victoria, BC, Canada.
Awesome.
But we have people all over the world that tune in. So yeah.
Well, I really appreciate everybody tuning in from all over the world. I run a unit in Boston for young people with emerging signs and symptoms of borderline personality disorder. And, we opened in 2007 and have had, thousands of young people come through us. And one of the, I suppose, sadnesses is the experience that many of our patients have had, not only in the world that it has been pretty stigmatizing, but also by the mental health profession. I really blame my profession for having stigmatized the condition of borderline personality disorder. Okay, next slide. Okay, so this is one of my patients who's an artist, a really talented person, and not somebody who does as much talking as maybe other people, but really wanted to capture her experience of the sort of language and the thinking that she'd experienced in different settings, and that she'd had this kind of idea, and it took her a long time to sort of put it together. Hearing clinicians use the term raging borderline, manipulative, attention-seeking, and these kinds of things. Also hearing in other settings, like finding out that somebody else had, say, BPD, and hearing, oh, they're the worst. A lot of eye rolling, the idea of people as BPD as monsters, and the idea of before understanding the diagnosis and sort of separating it from I'm a person with BPD, this idea that they were their diagnosis and that they were, because of this sort of really terrible person, and then hearing so many people stigmatizing this, and then just like living with that stigma, and then being very, very afraid of saying, okay, I need to get help, but then also just hearing, oh, these people are terrible people, and so on. So this was, I thought, a beautifully captured a piece of art from one of my patients. Next slide. The other thing that's been really in the news a lot has been the Amber Heard Johnny Depp trial, and very few people have watched the entire trial, but certainly what gets put out on social media is the worst of narrative. So, for instance, we hear psychologists saying that the people with the condition can tend to be victim or play princess roles, use words like it can manifest constantly seeking attention, being excessively emotional, dramatic or sexually provocative to gain attention, speaking dramatically with strong opinions but few facts or details. So you look at language like that, and and again, I have not seen the entire trial, so there may have been other more compassionate descriptions of BPD. But here again, we see a diagnosis being made on the basis of what you see in on social media and in narratives, but there's nothing here that speaks to the diagnosis based on DSM criteria. And so the other part of it is that it focused a lot on her personality, but a lot of the transcript shows pretty awful behavior on his part, and we don't hear in terms of diagnosis about him. So it's been interesting that I've been hearing from a lot of people saying, what can we do to start to challenge these kinds of narratives so that the broader population gets a clear picture of what this condition is. Next slide. So these are just some ideas that I've put together as I've been at McLean since 2000, run the BPD unit since 2007. And these are the commonly encountered statements that BPD cannot be diagnosed in adolescents and young people. Very, very dangerous position to take. I used to walk around with $1,000 check and say, the first person who shows me that you are prohibited from making the diagnosis under age 18, I'll give $1,000 to. Everybody would rush and go to their DSM. They couldn't find it because it was never there. But we are taught this in psychology school, in social work school, and psychiatry. But it does not exist in the DSM as a statement. People were cautious about making the diagnosis, but we certainly could see that older people with BPD, those who are in their young adulthood or even older adults, recognized that many of the symptoms actually did start in their adolescence, and the idea that you have to wait until you become an adult to get treatment is really worrisome in my mind and very stigmatizing. Some people just don't make the diagnosis at all. And, we often see this on inpatient units. There was a category in the DSM that was what they called not otherwise specified, or deferred. And so people would come in, and even if there were BPD symptoms, people would say, mood disorder not otherwise specified or deferred diagnosis. They're viewed as more difficult patients than others. And actually, this makes a lot of sense to me if I had BPD, in the sense that when you are not getting the right treatment, you might say, hey, listen, the person with bipolar is getting their lithium, the person with depression is getting their antidepressant, the person with schizophrenia is getting their antipsychotic. I'm not getting my treatment. And so, and when a treatment isn't working, people are going to be pretty upset by it. And so when they're upset by it, then they're viewed as more difficult than other patients. Sometimes it's the other way around. They're seen as less mentally ill and more able to control their behavior. And that's because of the fluctuating nature of BPD, that when somebody is in good emotional control and doesn't have the kinds of prompting events that trigger episodes of dysregulation, things are perfectly fine. And so think, oh, well, that person can actually control themselves. But they can control themselves when the provocation is small, but when it's much larger, it can lead to much larger kind of emotional disruptions, and then it's harder to control. But people then just say, well, look, you could control yourself yesterday, why not today? This idea of being seen as manipulative, as Marcia Linehan, the developer of DBT, used to say, if people with BPD are manipulative, they're terribly manipulative, because who wants to manipulate their way into hospitals? Good manipulators stay out of hospitals, or people don't know that they've been manipulated. So it's again, this is also not a clinical term. It's interesting that in BPD, a lot of the language that is used is not clinical language. Imagine somebody with high blood pressure, being called, I don't know, agitated or pressured, or something like that. You say, no, this is what the blood pressure is, and it's high, and whatever it is. We use clinical terms. the idea that BPD was untreatable from the old literature, that because for the core symptoms of BPD, medications don't work, that psychiatrists ought not to treat a person with BPD, that making the diagnosis will further stigmatize the patient. Next slide. And these are, certainly common myths that we have found here on our unit, that people with BPD resist treatment. Wrong. People with BPD resist treatment that doesn't work. I would too. But people with BPD are suffering in many cases, and they want treatment. But the treatment has to be effective, because if you tell me you're going to cure me my headache, and I keep going to you and you don't help me with my headache, then I'm going to stop showing up, and then people are going to say, oh, well, you're resisting treatment. Well, I'm resisting treatment because you're not helping me, so I'm going to find something that helps me. That people with BPD angrily attack their treaters. And this is a myth. That we've been open since 2007, had thousands of patients come through us. We see angry outbursts towards treaters to be very rare. That people with BPD rarely get better. In fact, about 10% of people with BPD remit of their symptoms within 6 months, 25% by a year, and 50% by 2 years, even without extended or stable treatment. So people are going to get better. They only get better if they have intensive treatment by experts. There's no doubt that people with severe BPD need more expert treatment. But imagine that the only person who could treat your asthma was a pulmonologist in an intensive care unit. Well, that would be complicated. Most asthma can be treated by primary care physicians. The vast majority of people with BPD can be treated by a person who understands the condition. But yes, it is true that in extreme cases, especially with a lot of comorbidities, you need more expert care. But that's just a small subset. Recurrent risk of suicide burdens treaters with excessive responsibility and the ongoing risk of litigation. People and families of somebody that they love who has BPD are so grateful often for the expert care that they do get, or the compassionate care that they do get. They're not going into treatment to say, okay, who's the next person that I'm going to sue? And the problem also is that many people with BPD who do have suicidal thoughts and ideations want care because they don't want to feel suicidal. But I've heard many therapists say, oh, I don't treat suicidal people. But who's going to then treat people who are struggling this way? Or what happens is that the suicidal behavior goes underground and is never tackled. So this is also a myth. Next slide. All right, so why do we tackle the stigma? And this is just true of negative attitudes towards people with mental illness, housing and employment difficulties. And I've actually had a CEO commit to being very honest about mental health conditions in their family, and to be very open about that with potential employees. But if somebody has a physical disability, there's often accommodations made for those physical disabilities. But with mental illness, that you do get these difficulties, and most people don't ever disclose any sort of mental health conditions when applying for positions or housing. Maybe they don't want to seek mental health care help. It definitely has, if I think about COVID and the vast amount of billions and billions of US dollars that went into COVID and looking at deaths and all of that, which I understand needs to happen. But when we think about the suffering of people with BPD, we know that 40% of people with on inpatient units have comorbid BPD and its association with suicide. Where are the billions and billions of dollars for research and for treatment? People with shame. And then, on the other hand, stress of concealing psychiatric problems, that people want to be able to discuss their psychiatric problems, their mental health conditions, BPD. I used to have a lot of people saying, oh, when you treat my kid, they've got anxiety. And then, come to know that they actually have BPD, but the person's had to conceal this, and just how awful that is for people with BPD. Next slide. So, one of the things that I've said to people looking for care, and that clinicians themselves should talk about is ask the clinician, do you routinely disclose a diagnosis of BPD? I've had cases where a person would say, oh yeah, I did disclose the diagnosis. I said, when did you do that? And they said 2 years after the person came in, and because I needed to get to know them. But often this will declare itself within a few sessions, in terms, and careful assessment can lead to a clear diagnosis. And then if they're not doing it, why aren't they doing it? And are there any risks or benefits of doing so? And then what experiences have you had, positive or negative, in sharing a BPD diagnosis with the patient? It turns out that in our research that about 80% of people with BPD correctly diagnosed find tremendous relief that they've been accurately diagnosed. Next slide. People say, well, the diagnosis of BPD can be difficult to make. Not really, because I think that somebody who goes down the DSM-5 criteria and is careful in their assessment can actually make the BPD diagnosis. Comorbid diagnoses can complicate the accurate diagnosis of BPD, and that's certainly true if, for instance, somebody has a severe mood disorder, say manic depressive illness, maybe a severe eating disorder, and that the thinking is compromised or mood regulation is compromised by these other things. So you might need a little bit of extra time. Certainly substance abuse, you can't get an accurate enough assessment of the mental status. And if you don't have enough history, it can complicate the accurate diagnosis. But in many, many cases, I've been told by clinicians, oh, this person has BPD. I say, oh, great, they sound like a good candidate for our treatment. Have you told the patient? And they say, no, I haven't. And it just befuddles me, because often what they'll say is, oh, you should get DBT treatment. And most of my patients are just very curious and very bright, and they go and look at DBT treatment, and they say DBT is the treatment for borderline personality disorder. So they then find out themselves, and they'll sometimes go back to the clinician and say, hey, I have BPD. And they say, yeah, I've known that. And I say, well, why didn't you tell me? So that's unfortunate when it's withheld. Next slide. In the past, and I remember, growing up in medical school, there were certain diagnoses that you just didn't make. People would talk about the C word, cancer. They would not disclose HIV. Now and in the old days, whether it's schizophrenia or other diagnoses that, wouldn't, people wouldn't make the diagnosis. But in this day and age, diagnosis is disclosed. And we know that when it is disclosed, there's psychoeducation, reduction of stigma, and encouraging autonomy. And yet, even though we do it for so many conditions, there's still a hesitance in diagnosing BPD. Next slide. So, when we ask clinicians why they don't disclose, some of them question, is BPD a real thing? And you only need to ask a person with BPD if it's a real thing to know that it's a real thing. But some question the validity. Some have concerns about the diagnosis being stigmatizing. But it's we'll talk about that. And then reactions within the therapists and within the patient, transference and countertransference. Next slide. All right, so what about this question of validity? You need 5 out of 9 criteria according to the DSM, which means that there are 256 different variations of borderline personality disorder. So if you walk into a room, you're giving a lecture, there are 256 people in the room with BPD. It's possible that every single one of them has a different set of criteria because it could be 1, 2, 3, 4, 5. 1, 2, 3, 4, 6, 1, 2, 3, 4, 7. It could be only 5, it could be 6 criteria, and so on. That sometimes there's that comorbidity with other diagnoses, that it seems to show up more in research settings. Now, the reason why I think this is because researchers are doing a very good assessment and evaluation. And the other thing is that sometimes, I had a clinician says, no, this person doesn't have BPD. I said, why are you saying that? It says, well, when they're not suicidal. The patient came in and I said, have you ever been suicidal? He said, yeah, I've been suicidal for the last couple of years. I said, well, did you tell your psychiatrist? Because your psychiatrist said you hadn't been suicidal. And he said, well, the psychiatrist never asked, so I never told him. So, sometimes people just refuse, avoid asking certain questions. And I would encourage people with BPD to say, you never asked about self-injury. You never asked about difficult relationships or suicidal thinking. Let me tell you about those things, because those are things that I also experience. Next question. Slide. There's a stigma that historically, and I've seen this on many inpatient units, that inpatient people can sometimes be scared of or frightened by people with BPD. I've seen people attack other people using BPD as a pejorative term, like, oh, you're being so borderline, to other clinicians, colleagues, and so on. But if you think about, like, okay, schizophrenia, or anybody else, or if they're in a manic state or maybe angry, that it's not seen as, they'll say, oh, that person had a manic episode. That maybe if they make the BPD diagnosis, that people feel hopeless and despair. That tends to happen when people go online and look at what others are saying about BPD, because there's a lot of misinformation that's online. I fear that BPD diagnosis will communicate an environmental what I meant to say here is that it's, it's only environmental and not biological. And what we know is that, and this was the great John Gunderson did a lot of this research, is that 60% of BPD is considered biological, because a person's temperament is considered biological, and that a sensitive person in an invalidating environment, can develop BPD. And so there's definitely biology. And that we know that people with BPD are more likely to have trauma in their lives. And we know that traumatized people are more likely to develop BPD. And that, you say, oh, this person has BPD, so therefore we will be insensitive to, maybe a traumatic situation in the past. Next slide. Again, that by leaning in to the diagnosis, people will fear, like, okay, that if I have sympathy or closeness with my patient, or hatred or fear for my patient, like, it's going to create more of that. When people with BPD do certain behaviors, that, do we trust them? Are they being honest? Do we give them the benefit of the doubt? That people are afraid of rage or again, self-destructive reactions. And actually, of course it happens, but it is the minority of situations in which it happens. People with BPD can often recognize that they have, kind of intense anger episodes. But what I have seen, because this is the way that I was taught about this, that people with BPD can have anger episodes. If you slow them down and then you think about, like, okay, let's think about anger, they'll often start crying. And often it's because anger is a secondary emotion to sadness, because often it's the sadness of feeling lonely, of feeling unloved, of feeling disconnected. And then when you feel sad, when you don't want to feel that sadness, then there's that secondary reaction of anger. And putting people with BPD in anger management actually makes no sense. We should put them in sadness management, because like in many situations, the circumstances are sad. Next slide. So that we notice that when we disclose that patients have more autonomy, there's a lot more psychoeducation, understanding the diagnosis. This is true of other diagnoses as well. That accurate diagnosis can guide treatment. I mean, if we keep calling people with BPD bipolar, then we're going to have to stick them on medications like lithium, which, if they have comorbid bipolar, it will work. But if you don't have an accurate diagnosis, and you put somebody on a medication for an inaccurate diagnosis, not only is the medication not going to work, but they're often going to have side effects to that medication. And the other thing is that in this day and age, there was a really fascinating statistic the other day that I found. The hashtag borderline personality disorder had 3.7 billion tags on TikTok. The next two were anxiety and depression with 2 billion. So what I'm saying is that people are discovering this diagnosis whether clinicians disclose or not. So I think that it is much, much better for the patient to have the discussion of the diagnosis with a compassionate, caring, thoughtful clinician, rather than have to find it on Dr. TikTok. All right, next slide. Now, autonomy, this is the standard of care in medicine today, that people are empowered, whether it's diabetes and self-care, whether it's rheumatoid arthritis and self-care, cancer and self-care. And to really not infantilize or patronize the patient, but it's saying this, you're part of your treatment. Respecting the patient's values and encouraging self-determination. It's sort of saying, we are partners in your recovery, rather than automatically saying this is what you need to do or this is not what you need to do, which just doesn't work at all, and especially not for people with BPD who don't necessarily like being told what to do, and especially when they've been told what to do and it hasn't helped. So this has to be a collaboration and a partnership. Next slide. Again, what we've discovered is that most people, when they get the accurate diagnosis, feel a tremendous amount of relief. If you go in and you say, hey, I've been wheezing, and the person says, okay, well, here's some nice hand cream. So for why? Well, you've got dry skin. And you say, okay, but what about my wheezing? And then you eventually find a doctor who says, oh, you've got asthma. You say, oh, wow, great. That makes a lot of sense. Now I can understand it. And so often with any other condition, you give the right diagnosis and it provides relief. Yes, this makes sense to me. Again, greater empowerment and mastery, more and more new treatments, and people are experimenting with different things, TMS and new kinds of medications. Can we make DBT sort of less cumbersome? Are there elements to DBT that help more than others? What about other treatments like transference focus therapy, mentalization, MBT, STEP, schema focus therapy? I can see some other edits I've got to make to these slides, but the point is that like a lot of these other therapies have developed on the basis of people being accurately diagnosed and trying different techniques. Next slide. Again, accurate diagnosis guides treatment, and this is true in all of medicine. And BPD should not be any different. So because if I'm having the thought, oh, this person has BPD, but I disclose depression, then my goals for therapy are going to be different from the patient's goals for therapy, because they're going to be looking at it through a different lens if I haven't been accurate in my diagnosis. And then you could also get realistic goals for pharmacotherapy and psychotherapy. And in this context, the the number of patients who come to us on polypharmacy, multiple medications that haven't really helped the patient, because what was medication was being used for was not what the patient was struggling with. And so if we make the right diagnosis, we say, this is what medication therapy can do, this is what psychotherapy can do. And maybe I don't have the skill set to be able to manage a certain level of BPD severity. But if I make the right diagnosis, maybe I can refer you to a colleague who might know more than I do, rather than me taking you on and diagnosing you with anxiety and giving you anti-anxiety medications and wondering why you're not getting better. Next slide. The other thing is, as I said, I mean, the number of patients who've told me that they found out about BPD because they self-discovered is just remarkable. And so I really, again, encourage people to say, look, just be real about this. Patients are going to find out in any case. And the other thing is, I've seen this happen where a patient said, oh, I wasn't told I had BPD. I said, how did you find out? They said, oh, I got my insurance billing and it was right there. Or what they do is they request their medical records. And they said, oh, I was being treated for depression, but then the medical records say that they have BPD. Or again, TikTok, or referral for treatments like DBT, MBT, TFP, etc. They say, well, why am I going to this? And it turns out that they have BPD. So they're going to discover it in any case. And it's much better to feel that you as a clinician have been honest with your patient, and that the patient can trust that the therapist is going to be honest with them. Next slide. So these are the positive reasons for diagnosing BPD. This little acronym, for those of us who are in DBT, we love acronyms. To reduce polypharmacy, it recognizes complexity. That actually BPD, and Mary Zanarini here at McLean says that BPD is a good prognosis diagnosis, that most people over time get better. So, and that's not true of all conditions. Validation that that people feel much more validated when they and their families know, and then the provision of effective therapy. Next slide. It's interesting. These are just like under misdiagnosed, that 24% of people diagnosed with bipolar disorder make criteria for BPD, but it was not diagnosed when in terms of chart reviews and stuff like that. So, which is a significant amount of people who are not being diagnosed or being misdiagnosed. And that nurses reacted with greater negative intensity and less empathy towards people with BPD rather than those with schizophrenia or mood disorders, which, a person then going into an emergency room or to, might not say that they have BPD, because they're often going to notice kind of this more negative intensity. And my point to this slide is that we, the clinicians, caused a lot of the stigma for people with BPD, and it is our task to change that. And one of the things that we can do when we know these sorts of statistics, when we know that 40% of people on inpatient units have comorbid BPD, is we can do much more psychoeducation and start removing some of the negative attitudes towards BPD, and and then on inpatient units start to implement groups and trainings that target some of the symptoms of BPD. Next slide. What is not a solution is not to make the diagnosis. That is just simply wrong. mood disorder NOS is wrong. Uh, um, and also just to, uh, um, you know, use judgmental language like calling people difficult, even if they're under a different diagnostic level. This is a difficult patient with depression or a difficult patient with PTSD. That is just absolutely wrong, and it's highly stigmatizing, and it's patently unethical. Next slide. And again, I mean, this is not necessarily surprising. The people who receive information about treatment had more positive attitudes towards others if the disorder is attributed to a biological cause. But treatment information had no such effect if the disorder is attributed to a non-biological cause. So, that if we say, okay, look, this is not a choice. People with BPD have brain changes that are very prominent and has been shown in lots of research that show that people with BPD have excessive activity in the emotional centers of the brain and less ability to control that. And that's sort of biological. And one of the things that we're going to do now is try to show that when people do dedicated treatments like DBT, that begins to reverse some of those biological underpinnings of BPD. Because it's the same thing, like somebody comes in with a broken leg and you show it on x-ray, people have a lot of sympathy, but there's no x-ray for BPD. But there is eventually going to be, and I believe when we have much more powerful scanning technologies to show the disconnect between the parts of the brain that control emotions and the parts of the brain that activate emotions. And that's the thing. People with BPD know that they experience the surges of emotional dysregulation, and that's purely biological. Next slide. So this is just a final slide from my patient, that the BPD diagnosis felt like a tattoo, sort of on her forehead, and sort of taking BPD as not a badge of honor, or not like necessarily pride and grateful for having BPD, but that she could begin to say, this is the clinical entity of BPD. This is how it presents. And I can start putting all the negative commentary that loved ones and other people have put towards her behavior, and sort of understand some of the behavior through the lens of what happens in BPD. Rewriting some of those toxic narratives that have historically been made, often by people with BPD themselves. And that's because, you get told enough times that you're difficult, that you're manipulative, that you're attention seeking. And if you don't have a stable sense of self, you're going to start believing it. And so this is kind of at the bottom, she says, I'm rewriting the story, is like taking control of that narrative and no longer being defined by what other people, including clinicians, are saying. So, it is one of my sort of maybe it's a sort of a quixotic quests, but I mean, to really reduce the stigma of BPD. It persists, it exists. We're seeing it in the Amber Heard, Johnny Depp trial. But we, the professional community, we, those who struggle with BPD, we, the family members who love people with BPD, should all be part of the a movement to continue to tackle the stigma. So yeah, with that, any questions, Bailey? I'm just happy to talk about it, and thank you so much for inviting me and for doing this this BPD kind of awareness day.
Great. Yeah. Thank you so much. You covered such a wide variety of topics, and stigma is hugely important. I think that's a great topic for our Awareness Day. If anyone has questions that they'd like to ask in the Facebook community, people can do that now. I know that you released a book recently. If anything you'd like to tell our audience about that, you're welcome to do that now.
Yeah, well, this was well, I keep saying I'm not going to write any more books, but I'm always writing more books.
You have so many great ones, though.
Well, so it was interesting that when DBT for Dummies came out, for 3 days, it was at #1, not in psychology, not in psychiatry, not in mental health, in all of Amazon. And part of it is that DBT had so many great skills for people who struggle with all sorts of things. And the tragedy, certainly here in the United States, is that there aren't enough therapists and psychologists and mental health professionals to treat the massive demand that we have right now, which has been aggravated by COVID and all the restrictions. So I think it was a representation of people saying, we want new ideas. The book I'm currently writing is what happens when you have BPD and OCD together, because that's a difficult combination to treat. So I have a colleague, John Hirschberg at Shepherd Pratt, and he and I have finished the manuscript. The other book that I'm starting to write is a book on BPD in minority communities or emotional dysregulation, because I think, Linehan's work was really done through a pretty white-centric view of BPD, and that there are people in the LGBT community, people of color, people in ethnic minorities who might experience not only invalidation differently, but some of the symptoms differently. And if they're only being treated by white clinicians, I mean, there's a lot to miss. So we also want to, talk a little bit about that. But yeah.
That's great. I did notice that with like some of the examples in the textbook, like when I'm teaching the course. So I think that would be great, to have some variety in the examples too. So yeah, that's great. Yeah, and I really appreciate the conversation around adolescence and treatment, because I do hear that stigma over and over again about not being able to diagnose under 18. And I really do think that it's detrimental, because if we don't have early intervention and the ability to have early intervention and diagnosis or treatment, then there's that. Then youth it can be just really detrimental to youth's mental health, like whether or not there's more likelihood to have other diagnoses, say CPTSD, or other ongoing compounding factors because of that.
Yeah, and one of the things that I've been working on recently with teachers is the idea of introducing courses on emotion regulation in schools. We insist on physical wellness. Okay, everybody has to go and to recess and play soccer or whatever it is, but we don't insist that much in mental wellness. Physical wellness, yes. Mental wellness, no. And a lot of those abilities of being able to pay attention to what you're experiencing, whether it's emotions, thoughts, urges, and those sorts of things, is so critical. And right, I mean, sort of misdiagnosing or not diagnosing does lead to further problems. Imagine that you didn't allow your child to walk until they were 18. Well, they would lose out on not only lots of experiences, but they would have many other problems as well. So the sooner that you find a problem, the better. So
Yeah, exactly. Like I think like the earlier you diagnose and treat a situation, then it's less likely that there's going to be other compounding factors in the future that that youth face. And that's something that we're working on right now as a society, is fundraising for more accessible and affordable DBT-A programs, because it's just a huge gap in our community. and also getting access to DBT steps in school or DBT step in school, because I think that's like super important is to have those education programs too. Yeah, and so I guess just like one to leave on a positive note is asking about maybe like what gifts or strengths do you see in folks, or success stories or anything like that? Like, what do you see as strengths of people with BPD?
Yeah, so I mean, this is, for instance, I mean, I love this art. I mean, I think that this person's experienced it so well. The people, the people who come to our unit are often very ultra sensitive, which is very consistent with BPD. But with that sensitivity comes creativity.
Mm-hmm.
A lot of creativity, music creativity, artistic drawing, acting, composing, all sorts of writing, creativity. I also see that one of the great joys in recent times has been the number of patients that we treated back in 2007, 2008, 2009, who have emailed me and said that they are now therapists themselves. And highly sensitive, attuned, empathic people can be highly attuned, sensitive, empathic therapists, as long as they're able to control the very symptoms that they're going to be helping other people with. So I think that there's, in many ways, having BPD with the ability to control that emotional excess is just like wonderful, because you experience life in such a vivid, technicolor way. It's when you can't control it that suffering sort of comes in. So I do think that the creativity, the compassion, the engagement, the vibrancy is something that I see in people with BPD.
Yeah, thank you. I appreciate that feedback. That's my story, as a person with lived experience with BPD, and now getting my master's and comprehensively trained in DBT. So that's part of my story. So yeah, thank you. I really appreciate your coming today and talking with us about stigma and all sorts of different topics that are really important. And so thank you so much.
You're welcome so much, and thank you to you for putting this on and your audience. And hopefully we will meet again next year.
Yes. Yeah. Thank you. Okay. Take care.
You too. Bye-bye.
Bye.